Jennifer Neary. You can call me Jen. And I'm a physical therapist, again, right down the road, right at PTSMC. I'm going to start off with a little bit about me. I graduated from school all the way up in Bangor, Maine, believe it or not, Hudson University. So I graduated in 2019, so I've been practicing for about 2 years, and I've been treating vestibular disorders, or patients with dizziness, for about 1.5 years. I kind of fell into this. My last job I had, one of the therapists was treating it, and I was like, wow, this is really interesting. Sometimes you can get a patient in and you just do one simple technique and then they're feeling much better. So I thought, how cool is that to see somebody for one visit and then they're feeling okay. Now it depends on the dizziness, but again, I thought that was interesting. So I followed her around a bit and I've been seeing patients myself. I'm recently married. Woo, did it. I was supposed to get married last year, but COVID postponed it. So I'll soon be Jennifer Ashman, one day soon. By the end of this, so some objectives, I want you guys to understand what vertigo is. There are a lot of different subcategories under it, and I'll make sure we touch upon them today. The other thing, when to know when vertigo is more of an emergency, when you need to seek medical care rather than come and see a PT, right? So again, knowing the types of vertigo that we can treat as a PT, because there are a good amount of vertigo that we can treat. And then again, what am I going to do in my assessment? Because it can be a little bit scary, right? With vertigo, you've got that spinning sensation. It's uncomfortable, it can make you nauseous. So what do we do? And I think understanding that is important to know what you're getting into for the assessment part. And again, where to go. So, hey, 1 minute down the road. Okay. I don't know if anybody has seen this movie. I have not. So when I was going through this PowerPoint, I looked it up. I think it came out in like the late 1950s. So anyways, I think the guy's got a fear of heights, right?
Yeah. It's actually not about vertigo.
No, it's not at all. I looked into it. It's like, it was interesting to me. But so we're going to start off with what vertigo is not. Vertigo is, oh, that's okay. Happens all day. Vertigo is not lightheadedness. So there's a difference there. A lightheadedness feeling is more like we're going to pass out, right? You get that. Maybe you stand up, you're a bit woozy, and you feel like, okay, I got to sit down and take a break. That can be also from low blood pressure, right? So orthostatic hypotension, when your blood pressure just doesn't change the right way when we move into certain positions. Low blood sugar can cause a lightheadedness feeling as well as dehydration. A couple other things that vertigo differs from is disequilibrium. That's that feeling of being imbalanced. So maybe you just got off a boat, right? And we're kind of like walking around like we're drunk a little bit. That's more disequilibrium. Fear of falling, that's not vertigo. That's something different, something else. And maybe at a later date, if we want to talk about falls, I'll come back in and talk about falls. But a couple other terms that we have is oscillopsia. That is a funny term, right? That's a weird word. Basically, that would be your visual field looking like it's jumping across. So like a bouncy camera. That's one of the things sometimes patients can come in and complain of. And then dizziness. Dizziness is more of a vague term. It's very generalized. But again, patients come in all the time and say, oh, I'm so dizzy. And that's okay, because as the PT, we know how to differentiate out, well, what does your dizziness feel like? So certain questions we'll ask to kind of tease it out to see, okay, this is really how it's more so presenting. So again, maybe that's that like funny feeling in the head. People will say dizzy. But again, as a PT, that proper term is vertigo, but we want to make sure we differentiate. Okay, so we made it. What is vertigo? Oh my goodness, this is what we're here for today. Vertigo is that sense of spinning. So two differences here. Either like the room is spinning, the world is spinning, or yourself is spinning. So two differences, but both would be termed vertigo. And so that's, again, what we're going to dive into a little bit more. Okay, a couple types of vertigo. We have spontaneous vertigo. It can come on with no known reason. It could be episodic. It comes and goes, lasting longer times, like maybe a few minutes to hours. It depends. And then we have provoked vertigo. So this one's a little bit more common, I'd say, more so what I see in the clinic. So provoked vertigo, maybe you're moving positions. You go from sitting to lying down and you experience that sense of spinning, bending forward, washing your hair in the shower, experience that sense of spinning. And other types of vertigo too can be provoked by the visual field. So looking at like your phone screen, you're scrolling through, and just that movement causes the sense of spinning. Or watching TV, you're looking at your computer, and the movement on that causes that sense of spinning. So those are kind of the two different types of vertigo. Okay, so a little bit more into what causes vertigo, because there are some differences here. A couple things central nervous system wise that can cause vertigo. Strokes, right? Cerebral vascular accidents. If you have a stroke in a certain part of the brain, it can cause dizziness. Tumors, same thing. If the tumor's in a certain part of your brain, it can cause that vertigo to come on. Multiple sclerosis, just a common symptom of MS, can be vertigo, that spinning. Migraines, and then Arnold-Chiari malformation. I practice saying that one. It's basically when the brainstem kind of falls below, and so that can cause that dizziness too. That one's pretty rare. I don't really see that too often. Okay, so again, when we're talking about vertigo and strokes, it can be spontaneous, like I mentioned before, so it can be longer lasting, episodic, it can kind of come on randomly. Other symptoms of stroke that we want to seek immediate attention for, we have the 5 Ds that we screen for as physical therapists. So diplopia, being double vision, right? Dysarthria, trouble speaking. Dysphagia, trouble swallowing. Drop attacks, so becoming unconscious, fainting, and then disequilibrium, so being imbalanced. The other thing when we're thinking about strokes, we want to think fast, right? So fast being F, facial droopness, A, an arm weakness or weaknesses of any kind really, S, that slurred speech, right? S, slurred speech, and then the T in fast is time. We want to get to the hospital as soon as we can. So just teaching you guys some of those red flags that, again, as PTs we look out for, but...
would you repeat it?
Yeah. The fast?
Yeah.
Okay, so fast is facial drooping. So typically, right, that's on one side. A is arm weakness, but it could be leg weakness too. S is a slurred speech, right? We're slurring our speech. And then the T in fast is time. The quicker we get to the emergency room, typically the better the outcomes, the quicker we can get treatment. So again, just vertigo and strokes, and giving you guys some knowledge on what to look out for if you're feeling this way or you see somebody acting that way too. Okay, so talking about motion sensitivity. So I kind of mentioned it earlier, right? We're watching our phone, we're screening, or we're kind of scrolling through, the screen's moving, and you get that sense of spinning. That can happen a phone, a computer screen, a TV screen, maybe this presentation, hopefully not. So that can be due to us relying more on our eyes. So again, that happens. It's something to do with the vestibular nerve, but we're gonna go into that a little bit later soon. Yeah, so again, something that's due with that vestibular system, but I'm gonna get into the anatomy of the inner ear next. So this area of the inner ear is really what we're talking about. It kind of looks like a funky snail. That's how I describe it. And then you can see that yellow part here, that's the nerve. That's that vestibular nerve, the 8th cranial nerve going there to give us that supply, that input. Okay, we're going to talk a little bit more about the inner ear and why it's important when it comes to vertigo. Okay. The functions of the inner ear, right? We have it senses motion. So I'm moving forward. My inner ear helps my brain process that movement, acceleration. It stabilizes our vision. So remember I mentioned things about we can rely on our vision. So things I look for as a PT, I'm testing your eyes with certain head movements. Stabilizing the head on our neck, right? So just that movement there, that's the other thing the inner ear does for us. And then it stabilizes our trunk. So just movements like this. Right, I said the ear is more than just hearing. It does a lot for us. So, common things that go on with the inner ear in terms of vertigo. BPPV. Has anybody ever heard of benign proximal positional vertigo? Okay, we've got a few. It's common, especially as we age, and I'm going to go over the risk factors for BPPV near the end of the presentation. Again, some mouthfuls here. Vestibular labyrinthitis, vestibular neuritis, and then Meniere's disease. So again, maybe some of you are familiar with some of these, and maybe these are new terms to some of you, and that's perfectly fine too. Okay. So, I'm going to start off talking a little bit about Meniere's. Oh, you have a question? Oh, that's okay. Two, if anybody has questions, you can either raise it, but I'll save time for the end if anyone wants to ask anything too. Meniere's disease, typically it's a fluid functioning, or fluid fluctuating in the inner ear. It can make that inner ear feel like it's very full, sometimes full of water. It's also kind of rare. You'd have to see a specialist to be diagnosed with Meniere's disease. I'd say I've had a couple of patients come and see me with Meniere's disease. Typically that's managed medically, so by your diet, like a lower sodium intake can be helpful to manage Meniere's, and then certain medications. The best time to see a PT if you've got Meniere's is after that vertigo has stopped. So sometimes the vertigo with Meniere's disease can last hours, can last a day. A lot of the time those patients, they have days where they just can't do anything because they're so dizzy. So the best time to come and see PT is once those symptoms have subsided, to give you certain exercises and techniques that can help with that, hopefully the next time. Unfortunately, there's not great research with, is PT very helpful with Meniere's? As you can see, we put on here, physical therapy may be helpful. It's one of those things, worth a try, get the strategies, but again, we're not 100% with research showing that it is going to be beneficial. So it's a tough one to treat. Vestibular neuritis, okay, so that's a virus in the body. So we're thinking like a herpes complex virus, maybe the shingles, you had shingles, that's a virus in our body. The COVID virus, right, that's another virus. And that virus attacks our inner ear. So I was talking about the 8th cranial nerve, right, that vestibular nerve. That's where the virus kind of attaches to. It either is going to attach to part of the nerve or most of it. So again, you're getting those visual sensitivity issues. You're walking and maybe the room's spinning a bit, looking at a screen, you're getting the dizziness. But your hearing is intact. Hearing's okay. Here's what differentiates the two. Vestibular labyrinthitis, it's an inner ear infection that causes some swelling. But with this one, it affects our hearing. So again, as a PT, that's what helps me figure those two out. If I want kind of that next medical provider to be in the picture with me, the patient, where I'm sending them to an audiologist, so a doctor who specializes in hearing to help me rule one or the other in. And then sometimes I'll even send a patient out to a neuro-otologist. That's another big word. It's a neurologist who specializes in the inner ear. Those guys are all very helpful and great friends of mine. Okay, so the two of these, right, it's going to result in a loss of function. Most of the time it's one ear, but it can be both. I've seen it in both, and it takes longer to treat. It's either the entire inner ear or just a portion of it, right? So we have vertigo, maybe it's lasting a few days to a week, but as soon as you get into PT and we teach you, again, I'll explain why I'm doing this. I'm teaching you some of these techniques to help retrain your eyes with your head movement. And again, some of the things I'll look for too is I'm testing your balance. So certain things with balance, right? Feet together, eyes closed, what's going on with the body, right? If our feet are together, our eyes are closed, and we're like this, our vestibular system, is a little bit weakened. So there are a lot of clues that the body gives me that helps me figure out how to treat some of these things. And again, something we do as a PT. Let's see. Oh, maybe the video will work. No. Okay, I'm going to show you what the video did, and I'll show it on myself. So this little boy here is looking at a certain point on the therapist's face. So I'll tell my patient, okay, look at my nose. And we're wearing a mask now, so, okay, look at the tip of my mask is what I say. And then I have my hands on the head, and so I'm going to look at your nose right there in the blue shirt, okay? So if you're like, why are you looking at me? I'm looking at you. Okay, so we're doing these slow movements, and then fast. And then fast, and I'm seeing, oh, did the eyes slip off of the target and then come back? I know, sorry, it's much easier to see on the video, but you guys get the gist there. I'm moving the head quickly, one way or the other, with the eyes focused on the target to see if they can maintain what I want them to look at. Okay, here's the one, BPPV. I say that is most well known in the vestibular world. So benign proximal positional vertigo, it's a big one. Again, most common cause of vertigo, especially as we age. It occurs when we're moving positions. So this is a positional type of vertigo. We're moving from sitting to lying down, rolling in bed to the left or the right. Maybe that room starts to spin. Bending forward can cause that to come on, going up. You can think of like the dentist chair, right? When you're going back, sometimes people experience dizziness at the dentist, and that could be a sign of BPPV, so something you'd come and see a PT for. And typically when those symptoms of the spinning comes on, it lasts less than 10 seconds, but there are different kinds that could make it last a little bit longer. Okay, here's the snail. I don't know if you guys think it looks like a snail. Okay, so we have 3 canals in our inner ear. Don't worry about the names of them, but just the anatomy, a little bit of some background. In our inner ear, we have a sac that contains these little rocks or crystals. Those are known as otoconia. You can see that there. I'm just going to call them rocks in our head. We've got rocks in our head, okay? They live in this little sac in our inner ear. Sometimes the connections that hold those rocks in can loosen, and if that happens, a rock can slip out. I'm going to keep kicking this, and end up in one of these canals, one of the 3. So if that happens, we've got a floating rock in our inner ear. When you move, let's say, sitting to lying down, your brain says, hey, we stopped moving, but your inner ear, because that rock hasn't settled yet, is then telling the brain, we're not done moving. So the disconnect between our brain and our inner ear is what causes that spinning sensation to come on. Again, I try to explain all of this anatomy to my patients. Whether they want me to go more in depth, I will. And if they want me to be more vague, I will. It just depends. So there are a couple of ways we assess for BPPV, okay? This first one is called the Dix-Hallpike maneuver. So you can kind of see the patient sitting, the head is turned to the left, okay? Turned to the left. The therapist then brings their head down, and you can see the head is off of the table a little bit. So your head has to be extended in order to assess the canals properly in the inner ear. The other test we look for, or that we do, is the roll test. This one looks a lot nicer, right, than that one. This one we're like this. This one you're just lying on your back. Head quickly turns to the right, and I'm looking what's going on at the eyes. And again, I'm using the right or the left, but we do this on both sides, right? We've got 2 ears, 2 inner ears. Again, 2 different assessments we use to see which canal is involved for the BPPV. Okay. So here's the assessment. The video's not going to play, but you guys kind of saw what I did, right? The patient's sitting on the mat. She lies back. Her eyes are open. So I'm going to tell you too, the 3 things I tell my patient to do when I'm assessing for BPPV. The first thing is try to keep your eyes open. You can blink, but if you close your eyes, you're not allowing me to fully assess what's going on. The eyes are so, so important because they'll actually move a certain way, which is called nystagmus, and that gives me a clue. It's a piece of the puzzle to figuring out what is going on. So keep your eyes open. Tell me if the dizziness starts, right? And then tell me when it ends. So those 2 things are very important. I need to time it. Is it a quick onset of dizziness, or did it last a few minutes or a few seconds and then it came on? And did it only last 5 seconds when you were experiencing it, or did it last a minute? These are all pieces of the puzzle that as the PT we need to put together to figure out what's going on. This video too was just of the roll test. Same thing, right? Lying on the back, I'm turning the head to the right or to the left. The eyes are open. And in this video, if it was playing, you could see the eyes were doing that nystagmus movement. They were moving quickly away from the floor. So it's really interesting, but patients can also get a little sick from this. Nauseous is one of the things, right? Sometimes when we're feeling dizzy, we feel nauseous too. So I let my patients know, okay, you might feel a little sick after this. Give it some time, you will feel better though. Okay? So the treatment, I don't know again if some of you have heard of the treatment for BPPV, but the most common is the Epley maneuver or the modified Epley. So one of the things we use, so right, we're thinking of the canals in the inner ear like a circle. If I move the head against gravity a certain way, I can actually move those rocks back to where they need to go. Which again, it's very cool, and why sometimes patients get better after one treatment. And then sometimes I'll say, okay, I want to follow up with you in a week or 2, just to make sure that those symptoms are gone. So I'll recheck the canals and say, hey, we're good, or let me do some more treatment to really make sure that those rocks are back in place. And again, it's a very highly effective treatment. Like I said, somebody can come in on day 1, we go through that position change, there's position changes, and then they're good. Like, oh, I don't have to see you again. I love my patients though, so I want you to come back, but I understand if you're better. Okay. So here's the interesting part, the risk factors associated with BPPV. I think this is most important for all of us in here to understand. Typically, the risk for BPPV increases with age, so over the age of 55. So here are just some facts I got from some research done in 2011. So roughly 30% of 60-year-olds will experience BPPV at least once. And then look at roughly 50%, right, of 85-year-olds will experience BPPV. Okay, that's 1 in 2 there. That's a lot of people, so that's why it's important you know that this is something a PT can treat. Go here, get some help, because again, as we age, it just becomes more common. And ladies, we're just so lucky. It's a little bit more common in females than males. I can tell you I've had my fair share of males that I've treated in the clinic though too. If you have osteoporosis, that also just increases your risk of BPPV. Head trauma, so we're thinking like a car accident, concussion, literally shakes the rocks out of place. And then these are some other things science has kind of found. A low vitamin D level and then high total cholesterol can increase those risks of BPPV. Just a couple of things. Okay, so again, where to go for vertigo, right? We're talking either PT, if it's in a positional vertigo, right? You're moving, sitting to lying down, that dizziness comes on. A physical therapist is the person you want to see. After an acute episode of BPPV, right? So let's say you get this dizziness, but you're okay, you just want to get checked out, come and see us. Even if it's been a week and the symptoms are a little bit better, it's better to come in and get screened and treated for it than to kind of wait it out. And then again, when those symptoms persist. So even if you're experiencing dizziness and you're not really sure what it is from, coming to a PT is great because we're trained to rule things out. We're going to screen you for some of those red flags, right? Screening for stroke, screening for other central nervous system things, and determining, okay, this is something we can treat in PT, or no, this is something I want you to follow up with your primary care provider about, or see a neurologist for, or maybe, right, I talked about earlier, I'm going to get the audiologist and a neuro-otologist on board with me while we treat you through PT. Okay, so some of the things, come and see us, we can help you and I together figure out the right path for you. And any questions, because that was a mouthful. Yes, go ahead.
To come and see you, do you have to get a referral?
So most of the time, people can come direct access, which is great. Certain insurances, so for example, Medicare, you do need a referral. Other insurances, most of the time, direct access. But if you call our front desk person, Betsy, would be happy to explain, like, oh, this is your insurance. Yes, you can come and see us. But yeah, so Medicare, you just need, like, your primary care could say dizziness. I've seen that on the referral before. Dizziness is a symptom, but guess what? I'll figure out what's going on.